Good evening. Welcome, everybody. We are again thrilled to have quite some participants on our next Meet the Expert session this evening about managing stress and inflammation during anesthesia. So, welcome. Arceus Medical, who together with the Belgian Associations of Anesthesiology organizes this evening, where we are very grateful to. Thank you for the help, the collaboration, and the support in this event. Tonight we focus on a very important question. Can we control surgical stress and inflammation and hence improve clinical outcomes? What might be the pitfalls and success factors, and what are the best go-to approaches in this matter? Those questions will be answered by our two speakers, two experts in domain during this evening. We are very happy to have Professor Mulier here with us and Ignacio Gonzalez from M. Dolores. Ignacio will start this evening, this program on heart rate variability as a measure for the autonomous nervous system. Using heart rate variability as a way to measure the autonomous nervous system allows us to accurately monitor the patient's condition during anesthesia and thus adapt our approaches. Professor Mulier will talk about should explain us the question, should we block stress and inflammation during anesthesia? Professor Mulier works as an anesthesiologist in the Department of Anesthesiology, Intensive Care and Emergency Care in Bruges, in the AZ Sint-Jan Hospital. He has been also the chairman of the anesthesiology from 1996 till 2014, and he's also associated with the University of Louvain and an academic consultant in Ghent. So for the let's say, more extensive biography, I refer for sure to our invite. So I hope you all enjoyed this session, and I now give the word to Ignacio. After the two expert sessions, we have the availability to have a question and answers moment. So please plug your questions in the chat box. We will collect them and afterwards discuss them or transfer them to our two speakers. Enjoy it. Ignacio, you have to unmute.
Nacho, I think you have to unmute yourself so we can hear you.
Maybe, Professor Mulier, do we start with you? Then we can, in the meantime, check what is happening with Ignacio.
If there is a problem, I will start. Otherwise, it's not a problem at all.
Isn't it? Thank you.
Yeah, I will start sharing.
Okay, I give you the screen.
Yeah, okay, thank you. And I will have to put my slides on.
It should work, no?
Oh, okay.
Can you hear me?
Yes, we can hear you. All right.
Okay.
I stop sharing then. You can go, you can take back.
Thank you. I don't know what I did, but it's sorry very much. These technical issues, you never know. So I am sharing now my screen.
Okay.
Yes. I'm going to share it. Here it is. I hope that you can see my screen now.
Not yet.
Not yet? It's not there?
Sarah,
Yes.
you have to give Ignacio again the function to share.
Yes, but I don't see him anymore on the screen. I think it should be better that we continue with Professor Mulier, because you're out of the session. You're not on my screen again.
Okay.
I am here. Sorry.
I will give back the word to Professor Mulier.
Yeah. Okay. All right. And I go here to my presentation. Okay. All right. Do you see my presentation?
Yes.
Okay. All right. So normally we should have started with explaining how heart rate variability is working, but this will come a little bit later on. I would say no stress. There's always a little bit of stress, and a little bit of stress, maybe not that worse. But should we also block the stress and the inflammation during anesthesia? Let's go a little bit deeper in this discussion. This might be two different aspects, stress and inflammation, although both are quite good correlated. And the question is, are they important? Well, they might be important in daily life. And in anesthesia, stress is happening when anesthesia is not deep enough. That's what we all have learned. And what you also have learned is that inflammation, that's really a surgical problem. That's when surgeons are too aggressive, too traumatic, when they hamper the perfusion too long, or when they induce contamination, we have inflammation. So inflammation is the problem of the surgeon. Stress of too much stress may be the problem of anesthesia. But both seem so connected to each other that the question is, can we really have both independent? Yeah. Going on that, should we block stress and inflammation during anesthesia? What is surgical stress? It's a very difficult question. And is the size of stress a patient has during surgery, can we measure that? Is that related to the size of the trauma that the surgeon is inducing? And then we talk about minor surgery, intermediate surgery, or severe or complex major surgery. It can be also described as a short procedure of half an hour or something more than 2 hours. We have been trying to describe that to the surgical area that is exposed, being a small superficial incision, being very deep, or being a total laparotomy. Even in this study, we have been trying to measure the total amount of proteins that comes available in the plasma as a measurement of the total amount of stress, and that seems quite good to correlate. Probably chronic reactive protein may be the most important one creating these problems. We also know that we can just measure hormonal reactions. Hormonal reactions do reflect the degree of surgical stress. And in looking back to these groups of patients with minimal stress, moderate and major severe stress, we see indeed that heart rate, and this is in an old study, indeed is higher in these major surgery problems. The cortisol levels do reflect that quite well, and you reflect that 1 hour after surgery up to 24 hours, we see still a higher cortisol level, in major surgery procedure, at 5 days, it should be totally normalized. In minor procedure, we'll never have an increase in cortisol levels. In moderate situation, we'll have that only immediately after surgery. Next day, it should be already full normal. You can also look to other factors, norepinephrine levels, catecholamine levels, that also follow a little bit this approach. Even if we're giving anesthesia, we will see cortisol and norepinephrine levels rising and changing. If we give good anesthesia, heart rate shouldn't be changing at all. That's what we all have learned. But inflammation, how can we evaluate that? Well, inflammation is such a complex story with so many interactions that it is so difficult. Traditionally, we talk about an injury causing the initiation of an inflammatory reaction, followed then with vasodilation and swelling up, edema. And then we get a transition and resolution, and finally you get a full restore of the normal reaction, but it's never normal anymore. There are fibroblasts coming in, and you get a full, totally different tissue that is created in the area, the scars that is happening there. If we look to that relationship between the sympathetic system and the inflammatory system, they are so interconnected, and one is activating, modulating the other one. So the sympathetic activation is modulated by inflammation. So we will, if there is inflammation, there will be more sympathetic activation, and opposite, the inflammatory activation is modulated by the sympathetic system. So it makes sense to focus on the sympathetic system and to try to block that, like in anesthesia, in a way to get also less inflammatory reactions. But if we can block inflammatory reaction, and we all know that some of our analgesics are more anti-inflammatory drugs than our real analgesic drug, but work also analgesic. So both systems are so interconnected that it's always a possibility to work on both at the same time. However, if we look to how patients react here, like on cortisol level, we see huge difference in the individual reaction. We can say that high-risk patients will have high levels of cortisol, as you can see here in red, after a procedure, intraoperative, and even prolonged postoperative, while low-risk patients will have that increase too, but will come faster down to the normal levels again. Cortisol levels is something we cannot measure immediately. We have to take a blood samples and have to wait several hours before we get any result. And that's one of the problems, that cortisol is not an ideal tool to directly interact and control on what is going on. But as both systems are intercorrelated, we try to then to predict what factors can predict these. Is it the severity of the procedure, the duration of the procedure, as we saw already? Is it when there are more perfusion problems and ischemia? Or is it also contamination that is really creating that trouble? Or we can even look to the existing pro-inflammatory diseases or the patient status that can be having an impact on that. And on that last, I would just show you the importance of the visceral obesity. In visceral obesity, we have a lot of visceral fat cells that are continuously in transition. So visceral fats are dying and fasting and faster than the peripheral fats. And we see a continuously infiltration of macrophage, and they release continuous cytokines. So that's why we call the central obesity, the males with central obesity, we call them, they are pro-inflammatory. They are in a continuously inflammatory state. And based on that, they have more problems on cardiovascular system. And if you look on table 3 on the right, you will see that the factor that is predicting actually coronary artery disease is not the total body weight, it's not a BMI, it's not the subcutaneous fat, but it's the visceral fat. So the more visceral fat, the more continuous inflammatory reactions, and the more problems you will see. It's actually the proceeding of the metabolic syndrome, being hypertension, diabetes, hypercholesterolemia, and if that's there for 10 years, you will have coronary artery disease. And the way to measure that visceral fat, you can do a CT scan and calculate exactly the area of the fat sitting intra-abdominal. Again, a complicated method, but if you use the waist height ratio, now in one slide too early, waist height ratio, this parameter is the best one correlating to the visceral fat and correlating to the cardiometabolic risk factor. So I think that we, instead of measuring the body weight of the BMI and say, oh, this is a high BMI, this is a patient at risk, this is a patient in the ASA class 3, if the BMI is above 40, actually maybe it's not making any sense. We will have to look to the waist height ratio, and if the waist height ratio is more than 0.6 or 0.7, we have an increased risk of metabolic syndrome, an increased risk of cardiovascular problem, and I think these are the patients in ASA class really 3 and at a high anesthetic problems. This visceral fat is something that is not investigated. Also very recently now with the COVID-2 problems. And what we can see is that this visceral fat is one of the reasons of being more inflammatory and getting these patients more in pulmonary problems. So it was not being obese that was finally the high risk to get more severe COVID pneumonia, but it was being pro-inflammatory. It was the intra-abdominal fat, the visceral fat, the large amount of visceral fat that increases this risk to have more severe outcome and ending up in the intensive care. So in the intensive care, it was not just the obese patients, it were the male patients with central obesity and being there already for some time, not the young patients, but the older patients having a continuously metabolic syndrome problem. So also the patients with renal insufficiency and diabetes based on this same problem. And so the comorbidities, hypertension, diabetes, were associated with more severe COVID-19. Obesity itself was not really the problem in this group of patients. Stress inflammations, can we block that with high dose of opioids? That's really a quite important question. We have for a long time been thinking that we were able to block sympathetic stress sufficiently with high dose opioids and probably also inflammation. We will see perioperative stress when we're not giving sufficient opioids. We see tachycardia, hypertension, sweating, postoperative pain, but not all sympathetic and metabolic stress markers. And if you look, cortisol is always rising up, even if you're giving high doses of opioids, glucagon, adrenaline. So opioids probably are not enough to block all these reactions. Inflammation itself, is that reduced by the opioids? Maybe there are other drugs that are more effective in getting this inflammation down. Swelling, edema, the immune system, CRPs, interleukin, all these aspects are also increasing, and we are not good in that area at that time. Now, the question of the use of opioids actually is something that goes already way back to the time that we were doing balanced anesthesia. And when Cecil Gray described for the first time in 1946 the balanced anesthesia concept, he was talking about we should give narcosis, relaxation, and analgesia. Now, the analgesia word means give opioids, but at that time, no synthetic opioids were available. And even analgesia, by the way, was done more even with local regional infiltration. And in 59, and that he wrote in 1960, he wrote a new paper, a paper that's hardly ever cited, and because it was written out on the moment the synthetic opioids came available, like the fentanyl here in Belgium, and where he was writing, look, if we use the word analgesia, we might be going wrong, and people might think that we need opioids only to block the actually better reflex depression. And he said, in our balanced anesthesia concept, we should talk about narcosis, relaxation if needed, and depression of all reflexes. And that we can do also without opioids and with other approaches. And he starts investigating in the coming up years more and more other methods to block reflexes, not just by opioids, by other techniques. However, the amount of drugs available at that time were too limited to get there. The beginning of this year, in February, we republished his paper with focusing on these reflex depression 75 years after his first publication of the Liverpool anesthetic technique, telling that actually he was already looking forward that the right way was to block all reflexes, not just only giving opioids to get there. Now, after that period, we have seen the rise of the opioid anesthesia, also thanks to the synthetic opioids with, at that time, less side effects than the morphine product, shorter acting. And we started using extremely high doses actually to get a really stable hemodynamic. And if you look to the first papers that were evaluating these approaches, they were only looking intraoperative, and they're stating we have a perfect hemodynamic stability in every case, less intraoperative problems, lower dose of hypotensive hypnotics needed. We don't need high dose of pentotal and halotal. And this is great. They didn't look to postoperative aspect. They didn't look to outcome. They just looked to the number of deaths after these cardiac procedure. And as cardiac operations were the most severe and major, and opioids were doing very well intraoperative, they concluded that this approach probably was safe for every kind of anesthesia. A lot later on, more and more papers came out that probably morphine alone was not the only an ideal aspect. We even see that morphine is interfering in the healing process and even creating some kind of chronic stress. We also see psychological stress, and if we talk on that, makes women more vulnerable to infectious diseases. Acute stress induces mucosal repair, so stress on itself is very bad. And if you think, well, if we combine it with morphine, we see even a worse recovery from injuries. So we see that the repair and recovery of an injury is actually bad after giving an opioid. Now, surgical stress response was not gone. We might have stable hemodynamics, but cortisol levels were still rising. Inflammation was still going on. Even on that, Kellett, so many years ago, already concluded that the surgical stress response seems to be impossible to be blocked. Sympathetic stress increases the risk for cardiovascular complications, oxygen consumption, catabolic metabolism with hyperglycemia, with a lot of inappropriate inflammation. Several techniques are available, but at that time in '88, published here in our Anesthesiology Belgica, saying no technique is capable, effective, even high-dose opioids to suppress all these aspects. And stress-free anesthesia and stress-free surgery, actually, it's a not valid term and it doesn't really exist. Even with local region anesthesia and very high dose of opioids, we still have these inflammatory reactions that are not gone away. Opioid-free anesthesia was then a technique by which we have been using other drugs that also have an impact on inflammation. And we see on one side that if you use too much opioid, you get postoperative opioid overdose. Now, this is a rare aspect and lethal complication. We have many more minor problems of the opioids that are creating some trouble. But be aware, there's just a recent publication where they have been looking to opioid-free versus opioid anesthesia, remifentanil. But in that case, they have been using doses of dexmedetomidine at 30 microgram per kilogram total dose. This is extremely high. This is at this dose, these patients are not waking up fast. There are bradycardia, hypotension, and indeed they have seen some hemodynamic troubles. So if you look to this paper and conclude that opioid-free anesthesia is not the right way to go, well, you are right if you use the doses they have been using in this study, because at that aspect you will really create some problems. Opioids do have an impact on several aspects. They induce respiratory depression after general anesthesia. If you only look to the amount of patients really requiring some kind of reanimation of naloxone, you might say, oh, the frequency is extremely low, less than 0.5%. But if you include hypoxemia and bradypnea, obstructive breathing, you will get frequencies up to 40%. And the risk is increased for patients with cardiac problems, pulmonary problems, OSAS, or indeed when the high dose of opioids have been given also post-operative. There seems to be no impact of age, gender, and strange also not obesity itself of the ASA classification has no impact on the incidence of that. Opioid-free anesthesia is all about not using opioids intraoperative. We are not talking about post-operative, but the advantage is that you can reduce either your opioids post-operative or even give no opioids at all. And that's absolutely the value. To get there, it is local regional anesthesia if this is possible, or otherwise local regional anesthetics also intravenously, alpha-2 agonist, ketamine, magnesium in the multimodal approach. This is a little bit the approach we are using most of the time today to get there. Dexmedetomidine is a not fast-acting drug, so you have to load it up in time to get there. You can use the maintenance of the hypnosis with propofol or inhalation anesthesia. That's the same thing. And we use the dexmedetomidine only to block sympathetic system, not to sleep, not for the sedative effects. Post-operative, you have to add also classical analgesics, and you can continue in extremely low doses of lidocaine, dexmedetomidine, you see 0.1 microgram, not to have all those side effects, not to have the sedation effects at all. The autonomic system is blocked by dexmedetomidine, actually comparable to fentanyl when you looking to patients. And this is one of the early studies where they have been looking also to some kind of heart rate variability to see what the difference is. And as you can see, they could achieve the same aspect of sympathetic block here by using dexmedetomidine alpha-2 agonist. But on top of that, the alpha-2 agonists are also anti-inflammatory. And more data and studies are now looking to the anti-inflammatory effect of different drugs, and very clearly dexmedetomidine has anti-inflammatory properties, as has also lidocaine on itself, neuroprotective and anti-inflammatory. Also, if you look to a peritoneal lavage with lidocaine in rats now with an infectious inflammatory reaction, fatal peritonitis, you see a higher survival. So lidocaine is blocking inflammatory reactions too, independent of that. A lot of it might have to do with the problem of cognitive dysfunction and neuroinflammation, something we will see in every case. Even if the surgery is not on the brain at all, we will see the inflammatory cytokines released in the circulation, getting also through the blood-brain barrier by the amount of general inflammatory reaction, and in this way creating neuroinflammation and creating cognitive decline. And probably these are the mechanisms by which we sometimes will see in major surgery cognitive decline related to surgery, related to anesthesia. So the big question is, are we able to even block this inflammatory reaction in the periphery, block these cytokines coming and going through the blood-brain barrier and causing these problems centrally? Now, if you look again, morphine is in contrast to lidocaine and dexmedetomidine, is actually even stimulating the pro-inflammatory cytokines. And if you look here to the peritoneal macrophages, we see that they even release and produce more pro-inflammatory cytokines if we give morphine. So morphine doesn't seem to be the right product to block these inflammatory reactions. And maybe that could be the reason why the lidocaine and the dexmedetomidine is having on its own some positive effects. Big question is, how much should you give them of each drugs and how what? The big problem is that every patient is unique, react different. Today we are talking more about precision medicine, as nobody is the average. In every publication, it's always about the average. And there is also well noted what the standard deviation is. But then we are giving the average dose to the average patient. And most of the time, you're giving too much, or you're giving not enough at all. Therefore, we may probably have to stay away from the one dose fits all. And in one way we've been working already quite long is trying to predict by models. Models based on age, on weight, on sex, on genetics, on procedure. That's also what TCI also is trying to predict what plasma levels you will reach in this unique patient. And then hoping that the plasma levels required is in every patient again the same. But maybe we have to go one step further and measure also each patient, because the plasma level required is probably different for every patient. And that's what's called personalized anesthesia, where you're not only predicting, but you're also measuring the effect. And this way, we really have to measure the depth of the hypnosis, the depth of the muscle relaxation, and maybe the depth of the sympathetic depression, if that would be very feasible, the depth of this inflammatory reaction, of the depth of the metabolic suppression. And that's the patient is catabolic or not. And in these last two, we are still a little bit behind. There's not that much knowledge yet. But let's start off with one of these tools that is measuring actually the parasympathetic system. And if the power of the parasympathetic system is high, we assume that therefore also the sympathetic system is low. And that's here the null system, from which you will get a little bit more information on the technology in the next lecture. Just showing you here where we have a patient on an opioid-free anesthesia, and in which a low dose initially was given of dexmedetomidine, 20 micrograms. It's a very low dose initially. And we see that after induction, we see a drop of the ANI level, showing a level below 40, assuming there is too much sympathetic stress. So we have been adding another 20, another 10, another 10. So you see, I've been adding several times. Each time there was also here an incision. Another time of the incision, we had given sufficiently dexmedetomidine to be able to, but again, we dropped close to the 40 again, so I gave another 10 micrograms, and then you see rising up to a level of 100, totally parasympathetic power, no sympathetic stress anymore. In this patient, we needed 1.1 microgram per kilogram lean body weight of dexmedetomidine. This is, for me, a relatively high dose already required in this patient. But without these measurements, or we would have been giving everyone 1 microgram per kilogram, or we might have been underdosing our drugs together. Now, if you look to the hemodynamics, they are not always showing exactly what is going on. As you can see here again, we had the induction, insufficient sympathetic block, one other dose of extra dexmedetomidine, and after 5 minutes, gradually you will see in the increasing. We have the incision and inflation of the abdomen, again at 10 micrograms, and then we are sufficient. We are not at 100%, but I'm not going to these maximum high levels. There is no need to block it totally and use high doses of drugs, as long as we are sufficiently. And we were not able, as you look here, to the hemodynamics, the heart rate was continuously stable. The BIS level was close to the 60, what is great. We don't need to bring the patient too deep. And on the hemodynamics only, you would not be, there was never here hypertension, you would not be aware that we had periods of insufficient sympathetic block. Another case where we had also here and relatively high dose, 27, no, it was not high at all, 35 micrograms, was 0.5 micrograms in total, given of dexmedetomidine with some lidocaine and a low dose of ketamine, 100, very good parasympathetic system. On the moment we were giving ephedrine, we see this dropping down, creating actually here a problem. Perfect conditions, just enough to do the job here also. In another case, we see here, we are not at 100%. We have not been giving that total dose, 0.6 microgram per kilogram of dex, ketamine 50 and 10, 60 milligrams, lidocaine 3.2 milligrams per kilogram total dose. And as you can see here, an ANI level being sufficient. Based on that, we were able to be sure where we were at that time. Another case showing here at 9:46, we see here that the ANI level is showing too much stress. Hemodynamics is not telling they are perfect. We could not see anything on the hemodynamics of habit. Ventilation is perfect. Patient is sleeping deep enough. This level of 43, nice saturation, nice heart rate, good blood pressure. Everything seems to be perfect. Nevertheless, based on that, we said maybe there's still too much sympathetic stress. Let's give an extra bolus doses as we did, and gradually we see it rising up finally here above the 40 percentage. You see now that the heart rate even drops a little bit lower. We see in the same level of the BISLab. Blood pressure was dropping also a little bit more. And now we have sufficient suppression. What we wouldn't be able to do if we were looking only to hemodynamics and the hypnosis depth of level. Another case here, low ANI level, some tachycardia. Here it is clear, there's tachycardia, blood pressure seems to be normal. So it is clear that this patient will need like an harder dose. I would say in this situation, give an extra bolus dose. If you want to go fast, you use sufentanil or fentanyl, use an opioid that will be acting fast. You can use also lidocaine, dexmedetomidine. It will just take a little bit more time. If the surgery is already going on, use an opioid. If you still have time, you might be able to use a non-opioid to get to the same range. There are other also tools like the NOL, who is doing and measuring also a little bit comparable, and there in low NOL level compares to a high ANI level, and here the patient is doing the same. However, here in this patient, we are giving an extra bolus dose, and we see rapidly changing the ANI level to normal values, where the NOL is still saying that there is too much pain. Or too much nociceptive reaction. So the question is, maybe ears is more sensitive and faster in detailing this, what is happening. The heart rate variability is actually one of the aspects that is really telling in major abdominal surgery. More than only that stress, and that's where it also is probably measuring the inflammatory effects and the high frequency power of heart rate variability. What the ANI is actually measuring is showing more the patient with acute respiratory distress syndrome and the need to be admitted to an intensive care. So patients where we were not able to get the stress down, where we're not able to get the inflammation blocked sufficiently, these are the patients who will require intensive care and prolonged follow-up. It's also something that's following very well the CRP levels, the chronic reactive protein levels that we will see right after non-cardiac surgery, general anesthesia, that we see that intraoperative nociceptive level and preoperative CRP levels were selected early to predict early increases in CRP levels after non-cardiac procedure. And these were also associated more with postoperative complications. So CRP is something that's very, very close to the inflammation. And therefore, as both systems are so interacted, by measuring the heart rate variability, we are not only measuring sympathetic system, we are measuring also the inflammatory system. With that, I think I will close. We were started a little bit 5 minutes later, so I think I'm still in time. Gaining control of the autonomic system, I think that is important for us as anesthesiologists, as well as in opioid-free anesthesia, as also in opioid anesthesia. In opioid anesthesia, we probably can give a lot lower amount of opioids as we are doing, and there might be selected patients where the opioid dose is not enough at all, and we need to give even more. So stress and inflammation also has its impact also perioperative on the posterior, and probably stress inflammation is not blocked enough today. We are able, besides the opioids, have drugs that are now better blocking also inflammatory reactions. So let's go and use them, evaluate how we are coming out. Now, each patient is so different, each procedure is different, and that's why we need actually to measure the effect, because just giving extremely high dose of an opioid is not done today anymore because the side effects are dramatically. Just giving an extreme high dose of dexmedetomidine is also not done today. You will also get a lot of problems. And if you want to reduce these amount of drugs, you really to be sure that you are not underdosing at all. And therefore, I think that the need of measuring the effect is of that importance. Like we are measuring more and more the BIS to be sure that our hypnotic level is right, we need to measure also the sympathetic and parasympathetic system and come to a personalized precision anesthesia approach. This is something true for the hypnotic doses, true for the muscle relaxation, and probably also true for the amount of nociceptive block we want to give. With that, I will give the word to Ignacio. I hope, and I will stop sharing. Stop sharing my screen.
Okay. Can you hear me now?
Yes.
Thank you, Jan. So I just changed my localization, as you can see. I hope now the internet connection would work better, and I am able to share as well my screen, and you are able to hear me as well. Is that the case? Can you see my screen?
Okay.
Is it there? Is the screen already?
Yes, it's fine. It's okay. You can continue.
Perfect.
Perfect.
Yeah.
Thank you very much. Finally, it's this internet connections. So, well, I'm going to talk about heart rate variability. Dr. Moulier has honored me in a way that he has set up very clearly the importance of the inflammation of the autonomic nervous system stress and the possibility to control it. And you can only control what you measure. And heart rate variability, it seems to be a good way to measure the autonomic nervous system response to a stress. So it might be a good tool in order to help clinicians to control that surgical stress. And I like very much to talk about heart rate variability as the fifth vital sign. That's why I took this image from Costa Rica, which his theme is Pura Vida, which means pure life. You can see the water, the life of the plants, the fishes, everything. And I like to talk about heart rate variability, the fifth vital sign, because heart rate variability is the sign that we get from the autonomic nervous system. And this system is the one that is managing the energy that is needed in order to be alive. Life is always about energy and how we manage it. And the system that is managing this life is obviously the autonomic nervous system. We are going to use this energy in order to fight or flight in case of the sympathetic activation, in case that we have an acute threat that we have to respond to. It could be an internal threat or an external threat, like a lion, for instance, or a bacteria inside our body that needs to activate the immunitary system, and that will be, as Dr. Moulier has done, thanks to the sympathetic activation. Or we have the other side of the coin, which is the Jan, if you want. It's the parasympathetic response, which is called rest and digest. It's the system that is going to take advantage of gathering energy and store it in order to use it in the moments that will be needed. And this balance between the sympathetic and parasympathetic is what is creating the equilibrium, the allostasis of our internal medium. And the disbalance of that is what it caused disease. We know always that the disease starts by a disbalance inside of the cells that is going to cause, obviously, cell damage that if that goes on, then it will create a tissue damage and a disbalance in all the systems that will lead into disease. So this is why we need to maintain this balance in order to be healthy. We know, and there are some articles already proving this theory, that heart rate variability appears when mammals were living in low oxygen environment. So heart rate variability somehow is a way to get the maximum energy from the environment. It appears, as I said, in the mammals when they were living in low oxygen environments. As they are multicellulars, we need obviously a pump, which is the heart, which is going to expend energy. And we are going to use that heart in order to collect the oxygen that with the glucose, we are going to produce ATP, which is energy. So we need to be very sure that the heart is not expending more energy than the one that we are going to collect. That's why the nuclei accumbens and the nuclei ambiguous are the two nuclei that are going to manage how the pump, so the heart, is spending that energy in a way that through the 10 cranial pairs, through the vagus nerve, that it's connected to different stretch receptors at the terminal of the bronchus, are going to detect when I'm in inspiration, and that information is going to travel to the nuclei accumbens, and it's going to stop the release of dopamine, and it's going to connect to the sinus node, releasing the sympathetic and stopping the parasympathetic activation, so the heart will beat faster. And the other way around, when we are in aspiration, the nuclei ambiguous will be activated, and the brake of the parasympathetic will stop the activity of the sinus node, making the beat-to-beat distance a little bit bigger. So we have this variation between beat to beat. It's not always the same. If that is the case, we are very near to death, as I will show in different papers. So if I have a person who is on a heart rate of 60, it doesn't mean that the distance between beat to beat is 1 second. There will be beats that will be lower than 1 second, and normally that will be during inspiration, and other beats that will be longer than 1 second, and normally that will be an aspiration thanks to the nuclei ambiguous activity. This is known from a long, long time. It's not a very new parameter at all. On the 60s, it was more analyzed, and it was thanks to the neonatologists that were looking at how the survival of neonates was bigger, or the other way around. The prognosis of the neonates were lower when this heart rate variability disappeared. So as I explained you, this distance between R to R are going to change depending if I'm in inspiration or in aspiration. In inspiration, the distance gets shorter, and in aspirations, the distance gets longer. And we can draw this in a paper, and we will obtain a tachogram in which we will see a sinusoid that is showing how the sympathetic parasympathetic balance is working. And the way to do it has been already established in these guidelines published some time ago in the 90s this is a document of consensus from the North American Society of Pacing and the European Society of Cardiology, and they made this task force in which they established that heart rate variability is the best way to assess autonomic nervous system, and more concrete, the high frequencies of that heart rate variability is showing the activity of the vagus nerve, or the parasympathetic activity. So as I was saying before, we can get this tachogram just representing graphically how the distance decrease in inspiration, as you can see the eye below, and increase in aspiration due to the long distance due to this ambiguous activity that I was explaining before. So this, in somehow, it's like the EEG of the autonomic nervous system, and we can analyze it as we did with the EEG. Normally, with Fourier analysis, we can do an analysis with fast Welle transform or with entropy. That is what we call a spectrum analysis or frequency domain analysis, but we can do as well temporal analysis or the domain measures, in which, for instance, we can calculate the standard deviation of the RR distance, of the root square deviation of the RR distance, that are measures or metrics already known, directly related to, for instance, the SDNN is directly related to the total variability of the signal, which represents the total power of the autonomic nervous system, or the RMSDDN, that represents, obviously, the activity of the parasympathetic. In terms of the frequency domains, we've got three very different frequencies. We have the high frequencies, we have the very low frequencies, and we have the low frequencies. The very low frequencies are directly related to the corticotrope axis and the temperature. The low frequencies are directly related to sympathetic activity and baroreflex activity, and the high frequencies, as I already said, because it was already described in the document of consensus, it's directly related to parasympathetic activity. And as I expressed before, heart rate variability has widely studied in neonates, talking about the viability or the capacity of those neonates to go over those births. And later on, it was used as well by the cardiologists using long-term measures through 24 hours of ECG measures. They were calculated offline, and they were able to see that there was a correlation to mortality in patients with cardiac problems, with low heart rate variability and mortality, as I said, and the other way around. Those patients who have a high heart rate variability, they were more likely to survive to those cardiology problems. And then from that, it jumped into the sports area, the sport medicine area, in order to be sure that overtraining does not occur. And nowadays, you can easily measure your heart rate variability through the camera of your phone. There are different applications that you can download. This is one of them, heart rate variability for training, or there is others like Welltori, or even you can measure your heart rate variability in those smartwatches. For instance, Garmin or Sunto or others have this measure, or with the Whoop belt as well. And this is just an example of my training for the marathon that I did last year, how the training was, thanks as well to good descanso, which means rest, good rest. You need obviously to enhance your sympathetic during the training and not overtraining, and then to have a good rest in order to allow your autonomic nervous system to recover. Then you can see that your parasympathetic and that your autonomic nervous system capacity is increased in order to be able, obviously, to face the big stress that represents a marathon. And that is just my improvement during the training. And you can see how the marathon caused a very big decrease on my capacity in the autonomic nervous system. So you can see here all the different applications, etc., that you can use daily. This is in the left side, you can see this application that is called Welltori that I used as well daily in order to see which is my stress level. This was this morning. I have lower stress and good energy in order to start my daily job. But obviously, we have the ENI, which is a medical device. It has not anything to do with the other ones. This is a very much precise and specific way to assess your autonomic nervous system. This is what you need when you are in the OR or in the ICU. The ANI, it's the acronym of of analgesia nociception index. But in fact, what we're looking at is at the high frequency normalized, so the percentage of the parasympathetic activity that I am having, and as well the energy, as I will explain you later. It's just talking to you about the total amount of autonomic nervous system, which represents your capacity to face the different threats that you're going to find. So as I was explaining to you, we are going to get this ECG, and from that we are going to get the TACOGRAM, which is like the EEG of the autonomic nervous system. And through fast-wave left transform, which is very similar to what happened to the light when it goes through a prisma, we are going to look for the different frequencies that we obtain, the VLF, the LF, and the HF, as I explained. And we are going to just filter out the high frequencies because we are looking for the parasympathetic activity. So we filter out the high frequencies, and we are going to pass away again, and this is what is different, the high frequencies information through fast-wave left transform on reverse, and we are going to obtain a curve. And for the first time ever, you can see the parasympathetic activity of your patient in real life. So this pattern, this green pattern that you can see here, the wider it is, the more parasympathetic you have. The full square represents the total autonomic nervous system, and the green pattern represents the percentage of the parasympathetic. So what we're going to do is just to calculate the area under the curve of that pattern, and we are going to obtain a number which is a percentage, and that number will be the yellow ENI or the orange ENI. The yellow ENI is the instantaneous ENI, and the orange ENI is the medium ENI that represents the percentage of parasympathetic activity that you've got in the previous 2 minutes for the yellow ENI or in the previous 4 minutes for the orange one. In fact, the yellow ENI will respond in 56 seconds. So if I made a stimulation, I will immediately see a change because it is updated every second, and it will reach the lowest value in 56 seconds, and the orange one will reach the lowest value in 2 minutes. And you can see as well, as I see you in this, as I told you in the screen of the monitor, the respiratory pattern that will tell you and will react immediately every second. This pattern change, and you can see that, for instance, you have a very wide pattern in a patient before the skin incision because the patient is with a good analgesia and a good hypnosis and very low level of stimulation. So it will be a wide pattern, which means a very high parasympathetic activity. And when the surgeon starts the incision, if the analgesic is not enough, then you will see that this pattern narrows very much. So the percentage of coverage decrease very much. So the ENI yellow will start to decrease rapidly, and so on the orange one. You can see as well another value that is called energy. Energy is directly the SDNM value. It's measured in milliseconds, and it tells you about the total power or the total capacity of your autonomic nervous system. In healthy patients, you will have total power between 0.8 or 1.2, 1.5. This is a healthy person, young person, a person who has a lot of health, if you want, a lot of vital capacity. And if you have a frail patient, that energy will be lower in that awake patient. So this is a parameter that could be very useful in order to assess if that patient may have any potential if I do a fast induction, for instance. A frail patient will have a value of energy around 0.3, 0.2 if he's awake. Anesthesia obviously will decrease that autonomic nervous system capacity, and in a healthy patient you will see values of 0.2, 0.5 normally. In a frail patients you will see like this one with an energy value of 0.08 or 0.09 in this case. This means that your patient is very likely to have a very low capacity of the autonomic nervous system, so you may have some problems. This could be as well a reason of overdosing of sevoflurane, for instance. No, allogenate normally causes very much decrease of the energy values. This is just the formula of the energy, just in order to show you that this is a metric of the autonomic nervous system, and it's exactly the same one than SDNN, which is known to be the total capacity of the autonomic nervous system. And this is the correlation of the ENI instantaneous and the ENI M or media with the HF-NU, which is very similar to HF-NU. The validation, we have nearly 120 papers talking about that, but this is probably the most interesting one, the FUNK study, which is proving that ENI is responding to nociception stimulation much better than heart rate and blood pressure. You see here the ROC curves of a tetanic stimulation and intracutaneous stimulation under propofol, and we took the reactions of different parameters like the pupil dilatation or contraction. You see the SPI, the surgical plethysmography index, and the heart rate and the blood pressure, and you can see as well the BIS number in the black dotted curve. So you can see that the highest area in the curve corresponds to the pupil contraction and as well to the ENI parameter, which is probably higher in the intracutaneous stimulation and a little bit less in case of the tetanic stimulation compared to pupil, but it's obviously over the 75% of coverage of the heart rate and blood pressure. But the most interesting thing is that when you add remifentanil, heart rate and blood pressure goes to 0.5, while the ENI stays on the 90% of coverage. This means that you cannot use heart rate or blood pressure when you are giving opioids to your patients, because the capacity of detecting noxious stimulations by heart rate or blood pressure is just the same one than tossing a coin. So when we decide to add more opioids because heart rate is going up, what you are doing is just tossing a coin. So you will be, it will be better if you use something much more specific, like it has been shown by the ENI. And the ANI, as I told you, is a percentage of the parasympathetic activity. So it's a scale that goes from 0 to 100. 100 means that the whole activity of the autonomic nervous system is parasympathetic. So probably you will not have an awake person in that case. Normally, awake patients will be between 50 and 70. If he's in comfort, he will be much around on the 70%. If he is stressed with a high sympathetic activity, he will be below 50. And this is just a publication that is correlating the ENI with the hemodynamics. And you can see that the correlation is just the 75%, because if we see the results as well from Funke, obviously we were nearly about 100% correlated to nociception, and 75% is the correlation of the hemodynamics to nociception. So obviously the correlation of hemodynamics with ENI is 75%. What we saw is that we react faster than hemodynamics 10 minutes before when we are talking about non-invasive blood pressure, and around 4 minutes when we are talking about invasive blood pressure. And we saw as well that when we have an ENI of 48, this is the highest sensitivity and specificity for detecting an hemodynamic reaction. That's why as well the index, we talk always to maintain the index over 50. And when we arrive to 30, there is always a 100% of probabilities of having an hemodynamic response in the next 10 minutes. And when we are over 82, there is no response at all. That's why as well it comes this 50-70 range. So ANI in the OR is useful in order to titrate analgesics, and it will be useful maybe as well to screen the frailty of the patients. This is the Upton study, the one that is showing that when you use ENI compared to an hemodynamic guidance group in laminectomy, in anesthesia, and fentanyl, and improve in the score of pain, in this case, RS scores. So the group of patients that are their fentanyl, their analgesics with ENI intraoperatively got scores of 3 and 4. Hemodynamics had a score to 7. And obviously, due to that, the amount of fentanyl given post in the hemodynamic group compared to the ENI group. And obviously effects as well. I mean, 92 more scores, 30 packs, more opioid area. So about in screening this frailty, it's an interesting editorial when it was launched that it's making this control of the autonomic nervous system important to our CI. Mulier already responds obviously yes, and they were saying preliminary results that low heart rate variability is a predictor of a weak aesthetic tone, a weak system activity, and independent predictor of mortality after non-cardiac. And there are papers already showing how patients with a lower heart rate variability before major abdominal surgery has postoperative morbidity had a lower heart rate variability. Or this other study that directly correlates the heart variability, so the SDNN parameter, or what it means, to increase of mortality fractures 6 months after the operation, with a in mortality than had a rate variability. Mentioned as well, ERAS program, what it obviously is the same thing that with training is to enhance the autonomic, repair the autonomic nerve in order to be able to go through the threat, which is sport, a marathon, or in the case of the OR, obviously this surgery. The ANI can be used as well in order to titrate, especially under mechanics. If we use it for just 1 hour and use it, we're going to have 1 week. And of course, it could be a predictor of mortality and prognosis. There is publications already. This is just a study that has been done in critical care patients. And I was able to detect them with a decrease in the value and the burst after that stimulation. And as it was proven that you can use the ENI with, this is just the case of an ENI monitor through the time in the ICU, in which you can see that, for instance, and comfort CNI, so it peak activity, and then you can increase it by a bolus of analgesic. We go 1 to 100, and then the pharmacokinetics of the drug, it goes, there is a drop in that value, and then when we end up the path, it increases. About the mortality publications in September or General that were set, so a low heart rate variability have an increase in mortality who have the power, obviously, or those with frequency ratio, which means a low sympathy has mortality than those a high ratio in terms of the sympathy, which will have a lower survival. this is exactly the same thing in case of septic pain, exactly the same. Those who have a septic process, what they need well activated in order to respiratory system, and those would be likely to overcome that septic problem. Septic cause that the autonomic nervous system and exhausted, and the sympathetic go down, and obviously those patients need to start with dopamine or that sympathetic activity, and that means prognosis. There are publications same way, just showing in ARDS patients that a low or high prognosis in terms of surveillance. And obviously there is a link, a direct link that has shown between heart rate, because it is nervous system activity, and that is managing the immunitary system, so inflammation as well. This is just, that is proving the relationship between of the heart rate variable interleukin-6 release with a very good correlation. Last but not least, this is a very recent study that has been done. It's a pilot, very preliminary. It has been published in PLOS ONE in COVID-19, which these doctors were proving that those patients who have low energy value and a high frequency value, which means high Bible, who had the other pattern, cover 80 and an energy value below 0, which has this capacity of predicting mortality with very good correlation. And these are just some screenshots taken from these COVID-19 patients, in which we have high ENI showing a high parasympathetic activity with a very, very low energy, 0.0 the other case. In these patients, if I have a sedation, what I would do the first thing is to the patient in order to see if the autonomic nervous system is able to react. And if that is not the case, maybe we need pharmaceutical solutions, or maybe we should be thinking another kind of activation, right? Maybe during the first phase of the COVID-19, mainly driven by sympathy, we should give this kind of beta blockers, or probably, etc., that will block that activation, and that very high may cause damage in the different tissues. Then what we need is to enhance, and one of those is probably parasympathetic stimulation. Already prepared, you can use even a TENS or whatever, and depending on the frequency through the parasympathetic nerve, you can activate the activation of the sympathetic or an approach just yet been proven that there's different, especially controlling the respiration. Maybe we could control this balance of the sympathetic and parasympathetic. Application made on the Leiru in hospital, in which we had different volunteers that were just using that was able to enhance the sympathetic activity. They was not able to do that kind of LPS intravenous, and they show that the group to control the sympathetic activation, so they were sympathetic activation, so their immunitary system to control the temperature and all the symptoms, injection perfectly well, while the other group are able to control, and they suffer this kind of use by this LPS injection. So that's another possibility. So in order to message of the autonomic nervous system variability, ENU and energy is total power, which will allow us to control how that surgical stress, get surgery, and this is the reason why I get better postoperative results with less postoperative acute pain, and obviously less opioids postoperatively. And it will allow us to, whatever it is, opiates, and as Dr. Moulier has been showing, in mechanical ventilation, in order to objectivize precisely which option that we are going to get in the different procedures for the patients. And another way to use it, obviously, especially, is to detect which is going to be the level of risk and mortality of our patients. So thank you very much. This presentation, I hope it was. And now I'm going to leave the space for some answers.
Okay, thank you, Ignacio. I thank you for this nice, also how the system, for many of us, variability. We are following the parasympathetic, and by that also the sympathetic. But for a long time, some knowledge in this area, dating these aspects, and it's easy for us to understand stability in a measuring of the sympathetic system. I had some questions here asking if this variability is not well measuring variability in the brain. You can be variability in blood pressure and aspects, but the sympathetic and the parasympathetic are affecting many of our function, and is affecting and indeed also the heart rate from the beat to beat. And it is a unique properties that is to get a view on this parasympathetic system. Yeah, okay.
I think that I understand. I mean, it happens to me as well. I was for a long time, and when I started to practice anesthesia, it was just a experiential way. I mean, they taught me some concepts. I was following those concepts, and I to the anatomy. I like very much normally in my presentation, not in this one, with a sentence which is a neuron. He says that all the actions, everything in the capacities that they are those of us, which makes as well our physical and that function. Because we have these that are stimulate the light, and they will transmit that directly into, and obviously the unknown or we have. But thanks to and I think that the system probably is one of the less systems. But it seems to be right now already known with the system or how sympathetic and the nucleus of the tractus rather with the ambiguous, and how this one is connected then to one of the organs. Obviously, there is a lot of organs that are going to be connected, because that's why I like to name the heart rate variability the field vital sign. The nervous system is the one that is managing all the organs alive, which is basically right of the life. So this is a quite well-known circuit now that we have that is controlled why the heart rate is changing his distance. Seems quite well known that this happens in order to an exchange with which is basically the cause of getting the energy of the day.
Okay.
And it's quite well known the relation with the simple dopamine release there, and that is that accumbens is responsible for actions for pleasure, you know. So and this philosophy, this concept of pain being like and pain, you know, this binomial concept. In fact, pain exists in order to get us away from something that is harmful for us, good for us. And it's very interesting to that and to the monitor them and things that it makes us well the other way around, you know.
Well, yeah, it makes, if you just talk about pain, it makes it predict what patient will have pain and who will. And it even has some pain after, and some patients will say waffleable. And I'm still feeling, and they're crying from, it seems to be, so that remains difficult. So also, it's not the task to have without pain only. I think that is short.
No.
To monitor how my patient will not have pain when he just is waking up. More than that, bit. It makes it also more difficult to evaluate. One of the aspects you also were telling and explain, mechanical ventilations. This method is working. If the patient not breathe, most of the time the not breathe extremely short face. But if the patient is breathing on his own spontaneously, the system is working too. Or do I have it wrong?
Yeah, well, this is related as well to something that I wanted to tell you before, and that it somehow give us the proof that interact with that. So basically, this variability exists. There is a change of pressure in the lungs, and these stretches are causing this heart rate variability. The way is to have a ventilation, a mechanical ventilation, constant ventilation. The monitor, if we are ventilating below per kilo, because we are not producing enough pressure, then so it's an apnea. It's the case. So apnea monitor will not variability anymore, and we have to have more main ventilation in order to produce as well this heart rate variability. In awake patients that are usually ventilating, in a good and stable vent. So if the patient is talking, for instance, then the measure will not be so reliable. The best way is to have, in fact, a mechanical ventilated patients, because you are giving a constant ventilation. And then we will see the changes that nociception is producing in that sympathetic parasympathetic balance that we are maintaining due to that ventilation. The point that I wanted to stress is to show, we thought it was utterly impossible to control, so we relax. But that I show you from that ICU, I mean, if you change on ventilator your ventilation, you will check our parasympathetic activity. And this is something that, if you make this prime ventilation, which is a long expiration and decreasing your respiratory, you will end up relaxed.
Yeah, well, maybe we can go back to Cecil Gray, where I was noting he was searching methods to get but the reflexes blocked. And one of his methods was using hyperventilation. So he was telling hyperventilation the patient is blocking the stress and the painful reaction. So analgesics, hyperventilating, and in this way, analgesia, we are, this is really a stupid and wrong approach, but nevertheless, there is an amount true in it. Hyperventilation indeed bring the sympathetic system a little bit in some sedated, and this way it has a very, very little effect. That already was 75 ago.
Right. And because, well, what I was saying, I was talking, obviously, as we build the concept, we have a wrong concept here, and this is due to the fact that it's quite was built on experience. When we started to describe about it, it was about pain, and pain only exists in conscious patients, because we know, I mean, so and need to forget pain, because pain never exists anymore. As if the patient is unconscious, we have is the reflex question, and that caused later on what we call interpretive inflammatory pain due to the reaction, sympathetic activity, etc., etc. But obviously, more complex than just level. I mean, it's just an alarm, and that alarm is caused not only by the cytokines and that are floating around your brain to your that alarm, but as the cortex is acting as well, you can have that sensation of having that emotional pain, and it can feel exactly in the same way. So pain is probably more cortical, and the reaction is more cervical. And
we are probably too much for the moment. I don't see any real question coming up, although I would ask, do any of things, have already someone using this device, and what's your aim at achieve? Is it like maybe opioids in a safe way, and where that it's really an approach to start using that? Or is it said, well, look, I'm not sure, and I really want to have my patient, when he wakes up, not to start quite a value. That's also probably in they are going deep. I really want to also maybe a little bit more, but probably to go at. But please react or chat if your question see us being interesting in this area to go. Seems into another robot anesthesia. Robot anesthesia, like you said, maybe it's not, and we are probably far away of that. I don't see as being giving continuous fentanyl infusion, so that would be we might end or controlling the dose end up in coming in a situation. This is the right approach to look in that direction. Not. Is anyone interested in reducing opioids, just in a way insufficient? We might be already a little bit, and I don't see action. So if someone, there was also quite small of our lecture. So if you really want, my email, contact me and ask for a PDF file or something to read it more closely. That the screen might be too small. Certainly, might be more difficult following it. The word back to Sarah.
Thank you, Ignacio, for sharing insights and pieces on the subject of evening. I don't see the end. No, indeed, there are no further questions. I also would like to send us a little evaluation, if necessary, is for a next expert event. All will link an email with a link of the recorded session of tonight. We'll have that you share them with your colleagues, interested doctors. Thank you for your attendance, for your interest. A big thank you for here and for your support and interesting collaboration during this session.
Thank you very
Thank
much.
you.
Thank you
Bye-bye.
all. Thank you.